Good afternoon. We are going to discuss about arteriovenous malformations. Vascular malformations are of following types: AV malformation, venous malformation, cavernous malformation, capillary telangiectasia, and AV fistula. These are most dangerous vascular malformation, AV malformations. These are congenital lesions, abnormal collections of vessels wherein arterial blood flow directly into draining veins without the normal capillary bed. Feeding arteries are there and needles or draining veins, and it can be static or a growing or a regressive. In presentation, the most common presentation is a hemorrhage followed by seizures, and then mass effect, ischemia, steal phenomena, headache, brute, hydrocephalus, and in pediatrics hydrocephalus and heart failure. Peak age is 15 to 20 years old, 10% mortality, 30 to 50% morbidity, and can present with ICH, intracranial hemorrhage, interventricular hemorrhage, or subarachnoid hemorrhage. Risk of hemorrhage when there is a high feeding arterial pressure, venous outflow obstruction, or depending on the size, location, or associated aneurysm or pregnancy. Hemorrhage related to AV malformation size. Small AVMs are more lethal than larger ones. Small AVMs tends to present more often as hemorrhage than do the larger ones. Small AVMs are thought to have much higher pressure in feeding artery. Lifelong risk of bleeding is 2 to 4% per year. A study of 166 symptomatic AV malformations with 24-year follow-up found the risk of major bleeding was constant at 4% per year, independent of whether the AVM presented with or without hemorrhage. AVM study group, annual rate of hemorrhage was 18% among patients who had hemorrhage at the presentation, 2% among patients with no history of bleeding. Rebleeding rate significantly lower than aneurysm. 7% of patients with AVM have aneurysm associated. 75% are located on major feeding artery, probably from increased flow. The symptomatic one is treated first. Although 66% of related aneurysm will regress following AVM removal, this does not always occur. Hemodynamic effects, pre-op effects, steal phenomena, AVM and aneurysm, and high flow angiopathy. Post-operative effects, normal perfusion pressure breakthrough or occlusive hyperemia. Cerebral steal phenomena. Autoregulation curve shift to the left. Then despite cerebral artery hypotension, focal neurological deficits are rare, less than 10%, and more likely to be local mass effect. Normal perfusion pressure breakthrough. Perioperative post-operative swelling or hemorrhage. There will be loss of autoregulation, occurs less than 5%, should be diagnosis of exclusion, and management will be prevention of post-operative hypertension. On evaluation through MRI, there are flow voids on T1 and T2 weighted images, feeding arteries, needles, and draining veins. Angiography, there will be a tangle of vessels, large feeding artery, large draining veins, and not all AVM show up on angiography, which are angiographically occult vascular malformations. Evaluation grading is done on behalf of Spitzer-Martin grade, outcome based on the Spitzer-Martin grade, 100 consecutive cases operated by Spitzer, and this is the classification. With the three features: size of the lesion, location, and pattern of the venous drainage, and the numbers are given accordingly. Treatment, multidisciplinary approach. Primary goal is decreasing the risk of bleeding. Then surgery will be the mainstay. Stereotactic radiosurgery, where there is a high risk for surgery, and transarterial embolization, that is adjunctive to the both surgery and radiosurgery. In surgery, American Stroke Association recommends the low grade, grade 1 and 2, for that surgery alone is enough, and for higher grades, more than third grade, before surgery we go for transarterial embolization. Surgery eliminates the risk of bleeding immediately, and seizure controls improves. Invasive, this is invasive, and the risk of surgery will be there. Surgery, pre-op propranolol 20 mg per oral QID for 3 days to minimize post-op normal perfusion pressure breakthrough. Perioperative labetalol to keep the mean arterial pressure 70 to 80 mm Hg. In surgery, we do first craniotomy, then dura opened, then identifying the borders and cauterization of the feeding artery. Deep dissection of the nidus, securing the ventricles, obliterate the draining veins, final removal of the AV malformation, and post-resection BP challenge. For that, hemostasis should be there. There's seeing for the residual nidus and areas prone to pressure breakthrough. Immediate post-operative perioperative angiography can be done. Premature division of venous, the complications associated are premature division of the venous drainage, extensive bleeding along the deep margins, post-resection breakthrough, or residual AVM. and we manage by packing the wall with avitine and gel fond and immediately removal of the entire AV malformation. Post-operative complications, subgaleal fluid collection can be there, sterile meningitis, wound infection and intracerebral hematoma. Post-operative deterioration is explained by normal perfusion pressure breakthrough, post-operative swelling or hemorrhage. There will be loss of autoregulation and management by prevention of the post-operative hypertension. Occlusive hyperemia, immediately obstruction of the venous outflow and delayed deterioration due to venous or sinus thrombosis. Management is adequate post-op hydration. Rebleeding from a retained nidus and seizures. Radiation treatment, we can give conventional radiation effective in less than 20% of cases, or stereotactic radiosurgery for small nidus less than 3 cm and deep AVMs. And radiation induced endothelial cell proliferation will be there that causes obliteration and thrombosis. Gamma knife, Linac, and these are non-invasive, which gradually reduces the flow and take 1 to 3 years to work and limited to small lesions. Endovascular approaches, that is transarterial embolization, usually inadequate if used alone for AVM because it may recanalize. Facilitates the bleed, helps in reducing the bleeding and possibly stereotactic radiosurgery. Can't be used alone, acute hemodynamic changes and multiple procedures required. Glue will be N-butyl cyanoacrylate, Lipodil or tantalum powder or D5. Embolization of the nidus through the feeders without any significant glue entering the draining veins. In general, only 2 to 3 vessels are embolized per session. Endovascular approaches, anesthesia by the MAC or GA, induced hypotension with vasoactive agents, general anesthesia or even brief adenosine-induced cardiac pause at the time of embolization to allow the glue to set. Provocation test, sodium amytal and cardiac lidocaine injection to determine that embolization will not result in neurological deficits. Anesthesia-related considerations, extensive blood loss, pharmacological brain protection and non-pharmacological brain protections. Monitoring required for ECG, SpO2, ETCO2, CVP, measurement of vascular pressures, differentiate artery from venous, and decision of whether a vein can be sacrificed. Anesthetic techniques, avoid cerebral vasodilators, general condition improve, and isoflurane or N2O, additional barbiturate loading, metabolic suppression by propofol or etomidate. Brain relaxation, for that good head position, CSF drainage, diuretics, osmotherapy, avoid excessive cerebral vasodilators, and modest hypocapnia with hyperventilation. Euvolemia and pressure control, required euvolemia and optimal cerebral perfusion pressure. Induced hypotension required for aneurysm or AVM, large AVM with deep artery supply, barbiturate therapy. Fluid and electrolyte management, isotonicity, stable cardiovascular status, prevention of cerebral edema, aggressive isotonic crystalloids may worsen brain edema by decreasing colloid oncotic pressure, or euglycemia less than 200. Mild toleration of modest hypothermia, mild hypothermia 34 to 35 degrees centigrade, cerebral protection, and emergency and recovery post resection BP challenge for that hemostasis, residual nidus or area prone to pressure breakthrough. BP control is the most important. Post operative management, BP control, systolic BP should be less than 120 mmHg for 2 days. Thank you.